A little too loud, I think. Okay, well, I will introduce myself very briefly. I'm Steve Nimer. I'm the new director of the Sylvester Comprehensive Cancer Center at the University of Miami. I've been a resident of South Florida for 4 months and 3 days. And so, thank you. And I'm also the chairman of the MDS Foundation, and so I used to be very close to the foundation geographically in terms of it being in New Jersey. I remain very close. We have weekly or every other week telephone conversations, and to make sure that the foundation meets all its goals, in particular the needs of patients with MDS. And so what I thought I would do, being the fourth speaker on the same topic, the question is, should I talk about what I want to talk about, or should I try to talk about what you want to hear about? And so what I titled it at this point, Controversies and Recent Advances. And so I'm going to probably go over some things that you've already heard about. If you've heard a lot about them, I'll go very quickly unless you'd like me to slow down. And if there's things you haven't heard about, and I'd prefer to spend the time in those areas. And I also wanted to tell you a little bit about the foundation if you didn't know that much. So the foundation was established in 1994. It's really an international group of physicians. There's a board of directors. And the board of directors is really all physicians and one lawyer. And the lawyer does virtually all of the work, and the doctors have all of the opinions. And so together we get things done. But it's a pretty unique foundation in that regard. There's not a lay board as such. And so it's really, if you look internationally at who are the leaders in MDS, those countries are represented generally on our board. So the mission is to provide education to physicians and to patients, and to provide some resources for the research, patient advocacy, and to make sure that patients with MDS get to the physicians who know something about the disease. You don't have to be at a center of excellence to know a lot about the disease. But if you know a lot about the disease, you're usually a center of excellence. Okay, so this is the foundation in Yardville, New Jersey. How many people have been to Yardville, New Jersey? Okay, me too. Yep, D. Okay, this is the high point of Yardville, New Jersey. So if you go there and you see the MDS Foundation, there's a Dunkin' Donuts, but other than that, that's about what Yardville, New Jersey is. We have social media, Facebook, Twitter. You can follow the MDS Foundation. I don't know if you do that. And again, we have the Center of Excellence program, which has about 150 centers of excellence. So there's 803 members, 460 patients, 343 physician or healthcare professionals. The board of directors encounters the UK, France, Sweden, Italy, Germany, the Netherlands, recently Japan and Brazil, Austria. We have nurse members and we have a lawyer and an accountant on our board. And then we've got a number of committees, executive committee. We monitor the centers of excellence so that if you are a center of excellence, it's not a lifetime membership, but we review over time to make sure you still meet those criteria. We have clinical guidelines committees, patient advocacy, scientific program committee, international nursing advisory committee, and we have a new development committee. And the goals are really to increase awareness, increase knowledge, help patients get optimal care, find a cure for this disease, and we have worldwide activities, support groups, and quality of life forums. These are the goals in terms of education, not just physicians and nurses, but pharmacists, There are lots of researchers who have PhDs who've never seen a patient with MDS, and they don't really know what it is or the impact. And then we want to influence government policy in this. I'm going to talk a little bit about government policy that relates to stem cell transplantation for MDS and Medicare. And we'd like to assist research effort in the MDS community. So every other year there's an international meeting. They're generally in reasonable places. And in May of 2013, the meeting will be held in Berlin. The last meeting in Edinburgh was about the biggest meeting ever had, and you'd be comforted to know that there's around 1,300 or 1,400 people who gather, and the entire meeting is devoted to MDS. Okay, so among the questions are, one, everyone wants to know, do I have MDS? And as you've seen, MDS is a morphologic diagnosis. So one of these is normal and one of these is funny looking. And I bet nobody in the room except for 3 or 4 of us can say which one is the funny looking, but you have a 50% chance of getting it right, okay? And so the question, of course, is do you have MDS? And the criteria can change over time. So there are actually papers written about how funny the cell has to look for it to be called funny, and then what percentage of the cells need to be funny looking. So you can have funny looking red cells, white cells, or the cells that form platelets. And for each one, there are criteria for how funny looking they're supposed to be before you can make the diagnosis. And so it's still, the diagnosis is an evolution. And this is one area of controversy. How can you be certain someone has MDS versus saying with certainty that someone doesn't have MDS? Okay, and then if you have MDS, the question is, what type of MDS do you have? Well, you will, so let me explain some things about definitions. So you've heard, I think Dr. Ferran said that, 19% blasts versus 20% blasts. 20% you have leukemia, 19% you have MDS, and even for a blast, I showed one cell, I could ask 10 pathologists, is this a blast or isn't this a blast? And they would have a difference of opinion. And so the question, what type of MDS do I have, is generally decided by a committee. So similar to this, there would be a committee that meets. Maybe there's 10 people. They sit around the room, and they decide, okay? They decide what are the criteria for MDS. And recently, the WHO reclassified the diseases. So one of the things, there used to be something called refractory anemia. That was a diagnosis. And there were patients who didn't even have anemia. They had MDS, they had a low platelet count without anemia, and their diagnosis was refractory anemia. And so that didn't make any sense because they neither had anemia nor was it refractory. And so now you can have refractory cytopenias with unilineage dysplasia, meaning if you have anemia and that's it, you can have refractory anemia. But if you have a low white count, neutropenia, you can have refractory neutropenia or refractory thrombocytopenia. And this is the first time that someone who has only a low white count wasn't given a diagnosis with the name anemia in it. And so now there's things called refractory anemia with a ring sideroblasts. And just to show you what happens, so this used to be called a ringed sideroblast. Sidero comes from the word iron, and so this is a cell in your bone marrow that has iron, and the iron is in a little circular dot, okay? So it looks like a ring of iron. So because it looks like a ring of iron, they changed it. It used to be ringed, but it's not actually ringed, it is a ring. And so this, I don't know how many man-hours were taken to change this, to drop the 2 ED, but it's dropped. And but again, in 4 or 5 years from now, there could be another group puts it back on again. Okay, and so it's very important that this is a little bit, when you go to medical school, it's like learning a foreign language. And so when doctors talk to each other, these things have very specific meanings. But most of the time, these terms don't have any meaning to patients, right? So, it would take you 10 years to understand what a sideroblast is. And it's not that important, except patients with ring sideroblasts tend to do very well with their disease, okay? And now, finally, there's some mutations that are associated with this condition, and this was recently discovered. It's one of the most exciting things in MDS, and I'm going to tell you a minute about it and then tell you that we don't have a clue as to what this means. But so we're in an era where things can move much faster. So as you've heard, we can sequence the DNA, the entire DNA of a leukemia cell or a cancer cell or of an MDS cell. And what they found is for patients with ring sideroblasts, that about 70% of these patients have a specific mutation in a gene that affects RNA splicing. Now, no one knows how RNA splicing should have anything to do with ring sideroblasts. But this was discovered about a year ago, and probably it'll take about 2 more years and then we'll know. And the reason it'll take 2 years is because we have the ability to move very fast on the research side in focused areas. Unfortunately, there aren't that many MDS researchers in the world because it's very difficult to study MDS. Every patient has slightly different disease, and we don't know which cell is started the whole thing. But the fact is that now we can study our MDS much better than we used to, and we're going to be able to figure this out. So, okay, what type of MDS do you have? The doctor tells you that. And then the question, of course, is what happens over time? So there are patients who stay very stable their whole life. There's patients whose disease gets progressive. Some of those patients develop leukemia. Some of those patients never develop leukemia, but they suffer from complications from low blood counts. And while much of the focus has been on how come these patients develop leukemia, we're beginning to get some understanding as to why over time, even without a change in diagnosis, the patient's blood counts can get worse and worse over time, okay? And so that's a focus of my lab, even the lab as I move it down from New York down to Miami. But there are lots of questions. But of course, people want to know what type of MDS I have, okay? And then you heard a bit already, is MDS a form of cancer? And the answer is yes, okay? Now, it used to be called pre-leukemia, but then patients who die from MDS most often don't die from leukemia. You can die from MDS without having leukemia. So to say to somebody you have pre-leukemia, the implication is you're going to get leukemia. But many patients with MDS live with, and they never develop leukemia at all. On the other hand, any disease that starts from a single cell, we think about, is this a type of cancer? And the answer is, most of the time, yes. Now, there are some types of tumors. For instance, in your pituitary, you can have a tumor that causes a problem. And in fact, it's not cancer. So our definitions are changing. Some people don't like to think of this as a cancer. On the other hand, anybody who's told they have a cancer, sort of you stand up a little straighter and you listen a little bit better. There's some people who are told this because we think that they will adhere to the therapy better than if they think it's just I have anemia. But the fact is that this is what we call a clonal disease, meaning it generally arises from a single cell. And I think Chris showed a beautiful slide, probably not so easy for you to understand, from the group at Washington University, showing how once the disease gets started, there can be different cells initiating it, some of those cells disappear over time, new ones appear, and so it's almost like a field effect, you know, a little bit with weeds. So you cut down, you see a few weeds, you cut down the weeds, sometimes one weed comes back, sometimes a different weed comes back, and that's a little bit when you're thinking of diseased bone marrow cells, that some can come and go over time. Okay, what is your prognosis? And you've heard, I'm not going to go into this very much, but again, the prognosis scoring changes all the time. So this is the IPSS, the International Prognostic Scoring System. It's based on the three things that are very important: what % blasts you have, what's the chromosomes, and how many low blood counts or cytopenias you have. But it's a little bit weird, okay, because some things you don't get much credit for and other things you have. And so this is heavily weighted towards the % blasts, and I'll show you why. So if you have 10% blasts, you get a score of 0.5. But if you have 11% blasts, you get a score of 1.5. So you gain 1 whole point by having an extra blast. On the other hand, let's say your disease starts out with anemia, and then suddenly you have a low platelet count and you have a low neutrophil count. Well, now you can actually be quite sick, but you would only get a half a point from that. So you may not know, it may be totally inapparent going from 10 to 11% blast. You may feel exactly the same. You can't figure out why the doctor's telling you there's anything different. But the fact is that it's heavily weighted in this way. And for instance, you could have life-threatening blood counts, and there's not a weighting system for that. And you heard there's not a weighting system for transfusions. So there's nothing in here that says transfused or not. And so that led to the WPSS, and now to the revised IPSS. And then after, there'll be the doubly revised IPSS, and then there'll be the revised WPSS. And the IPSS, although it's called the International Scoring System, has really been led by Peter Greenberg at Stanford. And so we use that in the United States. And the WHO, which is headquartered, I think, in Switzerland, maybe? We think of that, that's the European thing, and we don't like to use that too much. So there will be back and forth for sure. Okay, and then the other thing to know is what happens like with the karyotype. So karyotype is the chromosome abnormalities, and so in this iteration of the system, there's only a few things listed here, and then over time, now we've got all kinds of things to look for, okay? And so it's getting more and more complicated, and we not only know about gains and losses in chromosomes, but we've identified genes, and some of them are ultimately going to lead to new drugs that'll be useful in the treatment of this disease. And we're changing in terms of the prognosis here. Okay, so then you've got sort of what you have. You go to the internet, you look it up, you find out your prognosis, then you go to see the doctor. 99 out of 100 doctors will tell you, don't believe what you read on the internet. We're doing much better than that. And in fact, those doctors are saying that because it's true, okay? And so what I tell my patients is, I have no idea how long you're going to live, okay? But however long you live, I'm going to try to give you proper medical care. Okay, and that's the deal. So the question is what are the treatment options? Okay, transfusions, antibiotics, iron chelation. I'm going to get into that. These are options. Okay, hematopoietic growth factors. What those are hormones, things produced by the body that stimulate blood production. Erythropoietin, also known as Procrit or Aranesp. These are things that your body makes. These are things that you can read about not only in the medical pages of your newspaper, but in the sports pages, okay? So this is how people with EPO, this is how some people train for a big bicycle race or cross-country skiing race or other activities, because the more hemoglobin you have, the more energy you have, the more endurance and exercise. You've heard about 5-azacitidine and decitabine. These are called DNA hypomethylating agents. It's actually still controversial how these drugs work. Okay? For one thing, they take months to work. And why is that? If it's killing the cell, why does it take months to kill the cell? If it's affecting the immune system, well, that may be one way that they work. But the fact is that we're still trying to understand how these things work. And then you've heard that even while you're taking some of these treatments, they can stop working. We have no clue why they suddenly stop working. And we don't know how they work. We don't know why they stop working. We have a lot of questions and very few answers. Okay. In the old days, we would tell MDS patients, and in fact, for more of my career than we've had drugs, for a long time we had no drugs for the treatment of MDS. And so we used to tell the patients, well, you know, there's actually some good things about getting leukemia, because when you get leukemia, at least we have treatment, okay? And so now we have treatment, and the idea is to prevent you from getting leukemia. But in fact, there are patients with MDS who are treated appropriately for leukemia, even though they don't meet the definition of leukemia, and they derive significant benefit, and the disease can go away. But it's not so clear who will tolerate and who should get leukemia treatment for their disease. And so a lot of these things are individual decisions. And in terms of second opinions, you know, I think that everyone should think about getting a second opinion. And when patients ask me about a second opinion, I usually say, and this is what I would advise you, I'd say, okay, I'm going to give you a list of doctors whose opinion I respect. Why don't you see one of those? Okay? I've once told a patient of mine, because she wanted me to call everyone, all of her friends, because she had friends who knew an idea and things. And at one point I had to say, you know, I'm sure your butcher has a really good idea about what I should do for your MDS, but I probably won't listen to your butcher, okay? And so when it comes to getting a second opinion, you can get from whoever you'd like. I would recommend a physician, and I would also recommend somebody who's an expert in the field. Okay. Marrow and stem cell transplantation is curative. Unfortunately, very few people who have MDS are actual candidates. That situation is getting better and better. So it used to be if you were a Caucasian from Western European countries or Northern European countries, you could find a match. And if you were anybody other than that, it was very hard to find a match. But we now do cord blood transplants. And so if your mother is Jamaican and your father is Chinese, we'll probably be able to find a unit that would be suitable for your getting a transplant. And that's a very much of a change compared to even 5 years ago. And so our ability to do transplants, and you've heard we used to stop around age 55, then it was age 65, and now we transplant people in their 70s. It's not an age thing, it's more of a performance status thing. Lenalidomide, or Revlimid, works in particular in 5q- disease, and it works so well that we use it as a tool to try to understand what's wrong with. If lenalidomide is the treatment for something, and it works so well, if we can understand what lenalidomide does, then we can figure out more about what causes MDS, because we really don't know. And then there's a variety of investigational agents, and you just heard from Rami about those. Okay, so then what can you expect? Well, one of the questions is, if I get this treatment, what's going to happen to me in terms of my lifespan? So one of the questions, because these growth factors like erythropoietin or Neupogen, the question is, could any of these stimulate my bone marrow to turn into leukemia? And that's been a question. We still don't know with 100% certainty, but this is a study out of Sweden, and this shows that whether you get erythropoietin or GCSF or not, that people live the same. And in fact, it looks a little bit like patients who get erythropoietin and Neupogen as their treatments live a little bit better and have a little less leukemia than those that don't. This is not a randomized trial, but this is some evidence that tells us at least it's safe. So if your doctor gives you erythropoietin and G-CSF, there's no evidence that it can harm you and turn into leukemia in that regard. Okay. You've heard about 5-azacitidine and decitabine. It's very complicated to talk about this stuff, okay? How do I explain what DNA methylation means to you? I think the best way to say it is, you know, I've used the analogy of an accordion, which is continually being opened and closed, and so for in every cell in your body, there's genes that come on and turn off and come on and turn off, and that's a little bit like the accordion. Some parts of the accordion are open and some are closed, but then in the past we thought that DNA methylation was sort of the little key that you close the accordion with when you put it in the closet, and once that key is down, you can't open it up again. You've lost the movement. We now understand that DNA methylation is highly regulated, and it can be the methylation, and I don't know how many of you know chemistry, but a methyl group is a CH3. It's a carbon and 3 hydrogens, and it's stuck on a molecule, and now we know it can be taken off. And it can go through a series of processes, and this is a little bit like a code, so there's information. So if the DNA is fully methylated, is hemimethylated, is hydroxymethylated, each of these words is a code that tells the cell whether a gene should be on, should be off permanently, okay? So the idea is you give these agents, turns back on the genes, the cells in your body behave more normally, and then you get better blood production. That sounds good. There's no evidence that that's how the drugs work. Okay, we really don't know. Okay, and you've seen data. Okay, here's the trial. You've seen data, and the numbers are not so important. We tend to think more in percentages. And statistics, I think it was Disraeli or something that said, you know, lies, damn lies, and statistics, right? So you can do anything you want with statistics, but the fact is that if one of these groups lives 24 months and the other lives 19 months, then that's 9 months. So that's about 60% better, right? So if you get this drug, you may live 60% better than if you don't get the drug. And that's a very important thing, and that led to the approval of this drug. First, well, the drug was already approved in the United States. This led to the approval of the drug in Europe, okay? Like I told you, the IPSS and the WPSS, they don't like our data. We don't like their data. And so even with President Obama, you know, we still don't like their data. And so we won't approve a drug in this country based on European data, and they won't approve a drug based on our data alone. And there's an agency in the UK that has the name, the abbreviation of NICE, N-I-C-E. And the one thing about it is they're not very nice, okay? And so they tend not to approve drugs in the UK. And if you invite me for another time, Dee, I can talk about the role of government regulations. So that'll be a long time. We can spend an hour. This is a plot looking at trying to predict which types of patients benefit from 5-azacitidine. And it's too small, you probably can't read this. But this shows that if you're male or female, if you're over age 65 or under 65, no matter what your classifications are, almost everybody is on. This is 1. So if the thing is on this side, it means you're getting a benefit. And if it's on this side, it means the treatment is harmful to you. So almost all of these things are to the beneficial side of the curve, meaning that almost everyone who gets treated with 5-azacitidine in these kinds of trials will benefit. Okay. Now the other thing is, if you look at the complete response rate, is that the complete response, what is a complete response? Okay. Well, a complete response is, and you're going to get this down by now, is anything a group of doctors who sit in the room together decide, right? So we get to decide what's a complete response, and the way we define a complete response is really no evidence that the disease is present. We can't find it no matter what, and because it's a pretty strict definition, very few of the people who get these treatments get a complete response, okay? And so that suggests that maybe we're not giving the drug right, or we should learn something. And so there's a number of questions. So why don't these drugs work better, even though they give you a 60% improvement in survival? And the fact is maybe we're not giving them properly. So you've heard we give them 7 days in a row, we give them 5 days, then the weekend off plus 2 days. We give them 5 days. We have a lot of things that we can do. And so the fact is that we may not be giving them. The second is that maybe whatever we're doing to the cells over time, oh. You okay?
No. Yeah, I just want to lay down for a minute.
Oh, lay down? Okay. Why don't we just have you here? Why don't you just lay down right here? You don't have to leave the room.
I'd rather lay down on the couch up there.
On the couch. Okay, you sure you?
Yeah, I'm okay.
Okay, let me just take your pulse for a sec. You feel short of breath or anything?
Huh?
You feel short of breath?
A little bit, yeah. I had a tendency.
Okay. Are you lightheaded? Let me turn this off.
He was a little shaky before.
Okay. All right.
Sorry.
No. Come on. It's nothing to be sorry about.
I just want to lay down. I'll be all right.
Okay. Yeah, let's just see how it is. Okay. Let's see how it is for you to get up, though.
Yeah.
You want to move the chair instead, maybe, so he doesn't fall?
Yeah. Why don't we just take you in the chair?
Why don't we just move
Why don't
the
we're
chair?
just going to take you out in the chair.
Okay.
We'll hold the
I
chair.
have neuropathy in my legs, so I don't
Yeah,
have
yeah. Here we go.
Just move it one
Okay.
at a time.
Yeah.
Can that help?
Not so. Yeah, we can get him.
Just a little at a time?
Okay. Yeah. One at a time. Good.
You're having a hard
Just got to lay down.
Yeah.
I can get up.
You sure?
I want you to fall.
Okay.
He has no feeling in his legs.
Okay. Okay. So one of the ways that we can begin to examine how these drugs work. He's okay? Okay. Okay, good. Okay. All right. So, you know, part of our mission here is for you to understand a little bit how we approach these problems. And so one of the questions, so this treatment is given for 7 days every month. Or sometimes doctors say 7 days every 28 days. And that's different, right? Because a month is almost never 28 days. So do these, should this be given 7 days every 28 days or 7 days out of the month? And, you know, the answer is no one knows. And in fact, should they be given for 8 days instead of 7 days? And so there's a huge amount of empiricism that, you know, you take 2 aspirin when you get a headache. And has there ever been a study to show that taking 2 aspirin makes your headache go away? And the answer is no. But everyone knows that if you take 2 aspirin, your headache goes away. And then it says you should take the 2 aspirin every 6 hours, or every 4 hours, or every 4 to 6 hours. And then, is there anybody who's ever studied whether whether your headache will go away better if you take it every 4 hours than every 6 hours? And the answer is no. So what happens is somebody does it one way. It's a little bit like a recipe. And so you read the recipe, you read the cookbook, you give the treatment that way, but no one really knows if you didn't change the ingredients a little bit, it wouldn't be better. So these are the kinds of studies that have been done to try to address that. How can we begin to make progress? So the point is that these are hypomethylating agents. So the question is, if you can look at the DNA and see how long is the hypomethylation occurring. And the fact is that this is the starting point. Then the patient is treated for 7 days or 5 days. And then the hypomethylation is at day 11. And then around day 28, which is here, it's still less than it was up here, right? And so, it looks like they're all going up. So what this looks like is that if you want to build, so you have to take a cycle and then another cycle and then another cycle. So if you want to build on what the first and second cycle are, if you wait much more than 30 days, by the time you give the next cycle, the DNA's already gotten back to the original situation. And so when you see data like this, then suddenly you say to patients, I know you want to take a vacation here or there, whatever. I don't really want to wait much more than 30 days, okay, in between treatments. I prefer 28 days, right? And then, does it matter, okay? And this is the art of medicine. Some doctors will say, oh, it doesn't matter, come back in 7 weeks. And some doctors will say, we got to give this every 4 weeks. And for some people, it probably doesn't matter, and for some people, it matters. And to me, I tell people at the beginning, when we're trying to get a response, we should be very strict, okay? But on the other hand, if you've been on this drug for 8 years, and actually I have a patient coming to see me from Oklahoma, and he's been on this drug for about 6.5 years, and he doesn't, when he can get a flight and when the weather's good in Oklahoma, and he's not, at this point, and I don't know, but all I know is that I've told him that I would prefer he takes it every 4 weeks, and he tells me what he wants to do, and he wins. So, but it's good if you're driven by data. Okay. This is the 5q minus syndrome. Does anybody here have the 5q minus syndrome? Okay. So this is the first article I ever wrote after finishing medical school was on the 5q minus syndrome. It was published in 1987. And this is a syndrome, it's very interesting. It was first described by a Dutch guy. And he described it one way. And he called it then a 5q minus. And then later someone else described it a different way. And he lost the battle for the definition. So the patients that he described first don't really meet the definition anymore of the syndrome, even though he described the syndrome. But it's a predominantly elderly female. What does predominantly mean? Oh, maybe 70% of the patients with 5q minus are female and 30% are male. But if there's thousands of people, that doesn't really mean anything. But the red blood cells are big, okay? And the platelets and the megakaryocytes are, well, the platelet count is normal or sometimes increased. And you won't know this, but this is an abnormal megakaryocyte. It's called a megakaryocyte because it's bigger than all the other cells. And this is what makes platelets, okay, the megakaryocytes. And this rarely evolves into AML. So most patients with this do not get AML. And we know that lenalidomide works in these patients. And so it was very striking. If you look at like Procrit, patients who respond to Procrit, the definition is the hemoglobin goes up by 1 gram. So if you're at 8 and then you go up to 9, you may still not feel that great, but that's a response. So again, the doctors in the room decided that's a response, so that's a response. Now, if you look at the response in the patients with 5Q minus, that their hemoglobin went up 5 grams on average. Okay, so they started at 7 and then they went up to 12, okay, which is normal, right, or close to normal. And look at the speed of the response, 4 weeks. So this is a rapid and an impressive treatment. And the other thing that's impressive about it is its duration. Now, I wish the number was longer, but at least this goes out to 2 years. So half of the people who get this drug and who become transfusion independent, 2 years later, they are still transfusion independent, and we all have patients who are way out there. You know, I'm thinking of a lady from New Jersey. She's been on this drug 7 years now, and she's still completely, hasn't been transfused ever since. Okay, and the other thing that's interesting is that you can have, the chromosomes can disappear. The chromosomes are a marker of your disease. If the chromosomes disappear, it doesn't mean your disease has disappeared, but it suggests that. And in some of the people, it means the disease has disappeared. Okay. And then the last thing I wanted, I think this is, oh, there's the stem cell transplant. This is the next to the last thing, I believe, is iron loading. So you've already heard that a unit of blood contains iron, okay, about 200 milligrams of iron. So if you get transfused, you can have about 0.4 to 0.5 milligrams per kilogram per day. Why do we talk about iron? Well, the reason is the body has no way to get rid of iron, okay? And so what happens is when people get 10 to 20 transfusions, we can see the first signs of iron accumulating in the body. But that doesn't necessarily mean anything, okay? That means you can detect that there's a little too much iron in the body. And the question is, does, in an adult, iron overload affect your organ function or lead to death early? Okay. Now, what we know is there's a disease called thalassemia, and there are people born with thalassemia minor, and those people live normal lives, and oftentimes they don't even know they have thalassemia. And then there are children who are born with thalassemia major. And shortly after birth, they become anemic and they need to be transfused. And in the past, those children would live on the order of 10 to 15, 10 to 20 years, and they would die from heart failure, from iron overload. Okay? Now, you can imagine that if you're starting transfusions from the time you're a couple weeks old, and your heart is about this big, and then over time your heart is supposed to be increasing in size and function, that if there's too much iron all the time, that the heart function will be affected. But what's not at all clear is if you're an adult and nothing much is happening to your heart except hopefully it's keeping beating, but it's not really changing in size or function, whether if there's too much iron, it'll actually affect the heart function at all, okay? And if it's not going to affect the heart function, then maybe it's not going to affect your life much. There's some data that having a lot of iron will increase your chance for an infection. But again, if your chance of getting an infection is 1 in a million, and now it's 5 times more likely, now your chance is 1 in 200,000 of getting an infection. So it's not at all clear that that's going to be. So we monitor the iron. We look at serum ferritin. This is a blood test, so that's easy to check. You already heard it may not be that it doesn't correlate specifically with the iron burden, but when the ferritin goes above 1,000 or above 1,500 is the time when we start thinking, could iron overload affect the longevity of the patient? Okay? The younger the patient, the more likelihood the patient is to survive a long time, the more chance that the iron could affect you. okay? And so this is a very imprecise. And then there are other ways. What is one of the, you can have a squid test, okay? And this stands for the Superconducting Quantum Interference Device. In the United States, there's about 8 of them. I don't know if there's any in Florida. There's one at Columbia University in New York. It's the only one in New York. And so no one does this test, okay? But it's supposed to be the gold standard. But what people do is an MRI, and they do something called T2 star imaging of the heart. And the only problem with that is no one knows that that imaging has anything to do with heart function. And so, okay. So here are the questions. Is there an excess rate of heart mortality in MDS patients or of heart failure? I don't know. What's the median time between the beginning of transfusion dependency and cardiac failure or death? So if we use the example of the children, so now a child would be born and get transfused from birth, and then the child maybe by age 20 would die from heart failure. And so if you're diagnosed at age 80 with MDS, then perhaps if you get transfused, then you may die from heart failure at age 100. Okay? And if that's what's going to happen anyhow, then you can't really determine whether giving the drugs to get rid of the iron are going to make a difference. And so there are lots of unanswered questions. Okay. All right, so let's see what we'll do. Okay, maybe there's a slide coming. What are the conclusions? There's a term called best supportive care, okay? And what best supportive care means is giving antibiotics and giving transfusions. And there's also something called like elderly bias, okay? What is that? You go to the doctor, you have a problem. The doctor says, you know, look, you're blank age already. You know, what were you expecting, right? Come on, you know, we're not going to treat you. You're too old, okay? Now, the younger the doctor is, the more likely he is to say that, of course. But no matter what the age of the doctor is, it's ridiculous, right? It's not the doctor's decision. Okay, and so there is a bias, of course, so what the doctors will say, and you've heard this from the other speakers, this treatment is going to be too tough for you. Now, the fact is there are treatments that are tough. So if people are in their 80s and they get leukemia, it's very difficult to treat. The treatment involves a 4 to 5 week stay in the hospital, and so you have to be in good shape to tolerate something like that. But the drugs that we've been talking about, lenalidomide, 5-azacitidine, decitabine, these drugs have very few side effects. And so what I tell patients is, why don't you try it, okay? You try it once. If you have no side effects, and a month later, you will try it again, right? You try it once, you don't feel well, we'll stop. But I think it's unfortunate for patients with MDS who could benefit from the treatment that the doctors don't explain that these are serious diseases and the treatments frequently have very little in the way of side effects. And so people should try these things. So I think that saying to a patient, best supportive care, this is what we're going to do. Well, we're going to give you a little of this, a little of that. We'll see how things go. After all, how much longer do you want to live anyhow? Okay, and so you should tell the doctor, how much longer do you want to live? Okay, and then that's probably at least as long as you want to live. So, okay, you've heard about combination therapies. And so the question is, if you give drug A, then drug B, then drug C in order, can you achieve the same thing as if you gave them all at the beginning, okay? So you give them all, you have a higher response rate, but then if the patient doesn't respond to the combination, you don't have anything else to give. And so this is one of the questions in cancer therapy in general. What situations is there an advantage to combination therapy? Okay, and again, there are survival benefits for patients getting 5-azacitidine. And what we're trying to understand is if we can find out what's driving this disease, maybe we can block it, and then patients can live longer, blood production is better, and this is an important conclusion. Okay, so what else? How long have I been talking? I'm okay. Okay. I could talk forever, but the fact is, okay, so how are we going to, where are areas where we should be making progress? So one of them is mouse models. Okay, so, you know, it's much better to give a mouse a disease and study it than it is to have to take care of patients one at a time. So you may or may not know this, but when a pregnant female mouse usually has 8 babies, okay? So you can have 8 mice that are all related to each other. And so what you do is you engineer, you insert a gene that's known in humans to cause MDS. You insert it into the mouse's bone marrow cells, and then the mice get MDS. And then you can study the MDS a lot better than you can from humans. And then you can look at treatment in the mice. So you treat a bunch of mice, something looks good, and then you can take it into humans. Doesn't mean if you treat the mice and it doesn't look good, you can't still take it into humans, but this is very important. And this is the case for leukemia, and this is the case for MDS, this is the case for other myeloid diseases, the myeloproliferative diseases. And for MDS, there were very few models available in the mice, and now there are many. So there are many different models. They may reflect different aspects of MDS. And so this is going to lead to important new therapies based on these models. Okay. And then I think this is the last thing that I wanted to talk to you about, which is bone marrow transplant or stem cell transplantation for this disease. So the average age of an MDS patient is about 70. Okay? And so the average MDS patient is eligible for Medicare. Now, if you're 70 years old and you have leukemia and you want a stem cell transplant, the government will pay for it. Okay? Medicare pays for a transplant for leukemia. But Medicare has not paid for a transplant for MDS. And they say that there's no data. Well, that's not really true. There is data, but there's not comparative data. So what they would like is for you to take 100 people with MDS, take care of them, don't transplant any of them under any circumstances. Take care of another 100 people and transplant all of them. Okay? And then you have to show that the ones who got transplanted did better than the others. Well, the only problem with that is this is the United States, and that people want to do what they want to do. So just because you said to somebody, you're in the group that doesn't get the transplant, and then if they are a little sicker, and then the doctor says, you know, you should get a transplant, then they get transplanted. So it's not easy to come up with the data that the government wanted to see. And so it does not exist. So this, So what the government said is, if you will do a study, not where you randomize people, but just you do a study where everybody who gets a transplant is captured. How are the people doing? You present the data to us, and then we'll make a decision. The CMS will decide, okay? So what happened is we all got together and led by 2 groups in particular, a group at Stanford and a group at Dana-Farber in Boston. We wrote a protocol, and so now every patient over the age of 65 who gets a stem cell transplant in the United States goes on to the study, and then the data is being accumulated, and then will be presented soon to the government so that the government will pay for the transplants. So there are people who don't have insurance that would pay for this, and so it's another barrier that we're trying to overcome to be able to get a transplant. Okay. So I'd like to leave you, I hope, you know, I've been encouraging in the sense of the type of research that's going on. This is a search of the database. The good news is if you put in the word myelodysplastic syndrome and you put in the year 2011 and 2010, right, there's 1,623 articles published on MDS. So there's right now between 800 and 1,000 articles published every year on MDS. So this is another reason you should ask your doctor how many of those articles he's read or she's read, okay? And if they can't come up with at least 20, I'm kidding. But there's a ton of things. Some of them are not worth reading, okay? But many of them, and it reflects that finally, there are people studying this disease, and that's important. The MDS Foundation has been really critical over the years. You know, in 1994, I was 14 years old at the time, and so that made a huge difference for me. But the fact is before the MDS Foundation started, people would study leukemia. Okay? If you're going to study it, it's much easier to study leukemia than MDS. It's much easier to study breast cancer than MDS, or so many other cancers, because MDS, there's normal cells in your bone marrow and abnormal cells, and there's all kinds of issues related to the heterogeneity of the disease. Everybody's disease is kind of different if you haven't figured that out already. And so very difficult, so why not study a disease that's like one common disease? You'll make progress a lot faster, and the MDS Foundation has been very important in terms of this effort. And you heard already about this TET2. This is a New England Journal of Medicine paper showing mutations. This is from 2009. And the fact is that there are papers like this now every few months in MDS. People are making important discoveries. Okay, and I'm just going to go back. John Bennett, so I am the second chairman of the MDS Foundation, and this is John Bennett. This is a 1988 meeting where this was like the first MDS symposium, okay? And you can tell by the size of the glasses, you know, that this is a long time ago. And so John Bennett for, about 20 years was the chairman of the foundation, okay? And he was the one who led the FAB classification. And when it comes to figuring out if the bone marrow is looking funny or not, he defined funny, okay? So he's like the god of MDS. So if you have a slide and you don't know whether it shows MDS or not, you call him up. He's up at the University of Rochester. He snowed in half the year. Oh, he's stuck to his microscope, okay? That's how he got to be so good. Okay, and I think that's it. So I'm happy to answer any questions you have, and thank you for your attention. Yes. So there's one gene called RUNX1, right? You heard about that. So in fact, it's seen in MDS, but the mouse that when you can do those mutations in a mouse, and that mouse gets MDS. And so there are other mutations, P53. There are a number of mutations that occur in MDS. Whether there's something called a driver, and the others are a passenger. So the driver mutation would be something that causes the disease. But then once the disease is there, other mutations can simply be occurring, but they weren't what caused the disease. And it's very difficult. I always, one example, people were asking earlier about environment and genetics. And when patients ask me what caused my MDS, I like to say things like, let's suppose that if you were genetically susceptible, that ketchup causes MDS, okay? How would we ever figure that out? Everybody eats ketchup, and yet maybe 1 in a million people, when they eat ketchup after 10 years, they get MDS. It's impossible to figure this out. And so the mice are very helpful, because what happens is you introduce the gene to the mouse, but then it takes the mice live about 2 years, okay? So 1 mouse year is about 40 years to a human. And so you give the mouse this gene, and then 10 months later, the mouse gets MDS, which would be about 35 years old. So why did it take 10 months? Clearly, if that gene was enough to cause MDS, the mouse would have had MDS when they were born. But it takes all that time, and then you analyze the MDS in the mouse, and you can figure out all the genes that cause MDS. So,
Why is the mouse the animal of choice? Wouldn't you have an animal that was closer to human
yeah.
genetics or markings, or
Okay.
why the mouse and why not a chimpanzee?
Okay. So so mice are good, and zebrafish are good.
Zebra?
Zebrafish.
Oh, zebra
Fish.
Zebra.
There's these little tiny fish. They're about that big, and they have little stripes. Looks like a zebra. And when they lay their eggs, you can actually get like 50 zebrafish. Okay. So the reason how many people here would care if you killed a fish to help a human being, right? Okay. But the fact is that there's plenty of people who, if you even think about doing something in a chimpanzee, as you know, they can learn, they can have feelings. So, well, number one, it's a social issue. Number two, how much do you think it costs a month to care 40 fish, right? And to feed a chimpanzee and to take care of a chimpanzee is a huge expense. Plus, we feel they're brethren. Mice, most people don't feel that attached to mice. They have a big enough litter, 8. Feeding them isn't that expensive. Right. So that's mostly the reason. And the mice are it's unbelievable that both mice and fish, when you give mice cancer or fish cancer, it resembles the human disease very closely. Okay? So that's why.
You're not making a monkey sick.
Right. Okay.
Do you
Yes.
see any commonalities in your patients who are more successful in others than doing well with MDS? Do you see, I don't know, personality traits, lifestyles, diet, any commonality between them?
So we have a study that's a little too early, but we took 40 patients with MDS at diagnosis, and they stayed stable for years. We took another 40 patients, and they weren't stable. And we've been studying everything we can about the patients, and we've found some important differences already. So what our hope is if someone comes to see us, 2 people who look the same, we can do a study and say, although it looks like you're going to be stable, you're not going to be stable. And this person, although it looks like you may not be stable, you're going to be stable. I think you heard it earlier. What should you do if you have MDS to keep yourself healthy? I wish I had some very specific things. No, we don't have a clue. We know a few things. If you have a low platelet count, you shouldn't take vitamin E. Okay, vitamin E can increase your risk of bleeding. Now, there are people who take, then I get a phone call. I took 1-a-day vitamin. It says there's vitamin E 20 milligrams, but you may know that a single capsule of vitamin E is like 400 milligrams. There's people who take 5 of those a day. So a little bit of some things are okay. I think the goal, we'd all say something like a moderation, but there is nothing specific that can affect this disease that we know.
Do you encourage your patients to be active?
Oh, absolutely. I think, there's studies looking at depression, for instance, and if you look, almost the number one thing that treats depression in people is activity. So it's people who are very busy, who have a ton of things to do, it's much harder for them to get depressed as someone who doesn't have stuff to do. And if you take somebody who's depressed and you give them a lot of stuff to do, it's pretty hard for them to stay depressed. So activity is great. Dancing is very good.